I'm a little shorter. So this is my mom, Carolyn. Carolyn was pregnant at 16 with my brother. And because of that, she thought that my brother and I really needed to know about sexual health. That not only was it important for us to know about it, know about safe sex, know all of the things about sex, but that it was okay to have good sex. And with that, I became the point person on the playground to answer anybody's questions. So things like, can I use Saran wrap as a condom? The answer is no, but it is a good dental dam. Now, I also knew all the anatomically correct names for all the different parts. It was a fascinating thing. What I would realize later, so this is me as a new nurse at the Mayo Clinic at my first job, and I was working on the blood and marrow transplant unit. I did not know at that time how important what my mother taught me was going to be until I walked in to a patient's room one day, and they were having sex. So because of her, I was able to handle that situation with poise. And not only with poise, I was able to do it with respecting them and not making it judgmental at all. But what I thought about at that point is, why didn't they know that it wasn't okay to have sex after having chemotherapy? And it's because they were afraid to ask. And when I looked at the clinicians that I was working with, primarily the physicians, when I went to them and started talking about sex, they literally turned white and ran away with mutterings about like sexual health wasn't an issue. Well, it turns out that that's really not true, especially in the context of cancer. Sexual health is core to being a human, and to ignore it during cancer and cancer treatment just was inhumane. And it became a part of me that I really sort of pushed forward. And with this in mind, I started developing sexual health education, primarily for clinicians. And what was interesting is that the clinicians that showed up were always nurses. I never saw a doctor once in any of the classes that I taught. But I can tell you what we learned is how to be comfortable having conversations about sex and also explaining some key things to our patients. So much so that I started asking about sex and sexual health in every interaction that I had with patients. I did that once with a patient who was in his 60s. I opened the conversation about sex, and he honestly started crying. He hadn't had sex in 9 months because he thought that his cancer treatment was going to hurt his wife. Turned out that wasn't true, but nobody had talked to him about it. And so with that, I actually started doing research, looking into what is the evidence base in this field. Well, it turns out there is evidence, or was at that point, for men with cancer, but there was a dearth of evidence for female sexual health and cancer survivors, except we didn't have any interventions. But we actually started to have data that showed us that women were having these issues. So much so, this is a recent study that had about 3,000 people in it. 78% of the women in that study reported different issues with sexual health. Now, there's a list of them, but many of them had more than one. But less than 50% of those women asked for help. Now, this study, while it's important, it has been replicated in multiple countries. So this is one of the reasons why it's so important to me. The other is that sexual health in women is complex. And with that, it takes complex ways to solve the issues. Now, in female cancer survivors, sexual health we know has 4 key drivers: sexual desire, vaginal symptoms, body image, and partner issues. Our team actually uses this strategy. It's called the MOST design, where we test interventions for each of those predictors individually, and then during the optimization phase, we combine them to see which strategies work best for our outcome. And that's the phase we're at right now. We started looking at sexual desire, and our team actually did the testosterone and the bupropion studies. The other 4 are also important, but what all 4 of these showed us is that drugs and interventions that work in women without cancer do not work in women with cancer. So we needed different strategies. So we started looking for other options. Our team actually had an expertise in hypnosis. So we actually started developing interventions for sexual health using hypnosis. Now, hypnosis is where we put you into a trance-like state. And in that state, your subconscious is open to suggestions. So literally making suggestions around sexual health. The first one we did was actually for body image. And with body image, we tested that hypnosis intervention against progressive muscle relaxation. Both of them actually helped, which is awesome. but hypnosis actually worked better. Women were saying things like, I feel more sexual. I have more desire, which is exactly what we're looking for. So that was the first predictor. The next predictor is vulvovaginal symptoms. So there is actually an evidence base for vulvovaginal symptoms. That's when we're talking about pain, dryness, itchiness. It's vaginal moisturizer. When we looked back at that bupropion study, 70% of those women had vaginal symptoms that were not being treated, and they hadn't been recommended that, which is very distressing. So we actually put together a study called WISH, which combines vaginal moisturizer with our hypnosis intervention. We actually added suggestions for sexual desire in this one. We've now tested this twice. We're getting ready to do a third time. Very promising, and we're hoping to do a large RCT next year. So that's 3 out of the 4. The 4 is the partner issues. So we actually developed an intervention called psychosexual education partner intervention, right? So we call it PEP for short, that really takes that partner, it's an at-home intervention where it has them talk about sexual communication and intimacy, reconnecting with their partners after that. It also is promising. What I can tell you, though, this whole work, doing it in the context of this country, has been really interesting. And even more so now that I can't write a grant with the word sex in it. But that being said, my mom taught me that it's important to talk about sex. And I've done it so much that the high school youth group that I teach found out that I was doing a talk, and I'm now known as Dr. Sex. And I think my mom would be proud about this. And now I can tell you, she told me at one point that she thought maybe she talked a little bit too much about safe sex because she really wanted grandkids. But luckily, she was able to hold both her grandkids before she died with pancreatic cancer.